Perfect. Right. Good lead in, Yvonne. All right, everyone. Thank you for joining us for our Frontiers in Child Health Research Seminar. The seminar is held on the second and fourth Mondays from September through June and includes speakers with work focused on child health from both UCSF as well as guest speakers. Please let me know via email if you're interested in speaking or would like to suggest a speaker. Looking ahead to next month, we'll be welcoming Dr. Irfan Kathiria from the Department of Anesthesia. We are still virtual and using Zoom. We'll ask everyone to stay muted unless you have a question, and we'll also open it up at the end to questions. Today, we're welcoming Dr. Yvonne Wu from the Division of Child Neurology in the Department of Neurology. Yvonne's a professor of neurology and pediatrics and an investigator in the UCSF Weill Institute for Neurosciences. Her research is focused on investigating the antecedents and prevention of cerebral palsy through epidemiological studies and interventional clinical trials. Her work has been funded by the NIH, the Thrasher Research Fund, the CP Alliance, and the CP International Research Foundation. The title of Yvonne's talk today is Erythropoietin for Neonatal Neuroprotection, Journey from Bench to Bedside. Thanks so much for joining us, Yvonne.
Thank you, Roberta. Thank you so much for inviting me today. I wanted to share with you guys this journey. As we were just saying, it has been a journey, and many of you, or at least some of you on this call, have been part of this journey. So I hope I do service to explaining this story in a way that leads to some interesting discussion and some learning along the way. So I'll be talking about the use of erythropoietin as a potential neuroprotective agent for a newborn brain injury. And let's see what I'm going to do. Let me just quickly minimize this. Okay, is start with talking about some of the preclinical work. Much of it was done here at UCSF that suggested that EPO is a very potent neuroprotective agent. And then I will shift to the clinical realm and talk about the clinical trials that tested this potential neuroprotective agent. And I'll just say that, we just finished a large phase 3 trial, the HEAL trial, that showed that EPO was not beneficial and did not have efficacy in improving outcomes. And there's a similar large phase 3 trial looking at preterm infants. So both in the term and the preterm trials, the results of the trials were negative. And so at the end of this talk, I'd like to just kind of briefly touch on what are some of the lessons that could have been learned through this and what the future for erythropoietin neuroprotection might look like, if there is a future. So I'm going to focus mostly on hypoxic ischemic encephalopathy in term infants. Anyone who spent time in the nursery has seen these babies who are born with low APGAR scores, with acidosis in their cord blood. This is a significant problem. It's actually responsible for 1/4 of neonatal deaths worldwide, and is especially much more common in low and middle income countries. Since about 2007, therapeutic hypothermia has been the standard of care here at UCSF, and as well as in Europe and in Australia. And the early large trials found that if we cooled these babies after delivery for 3 days, that you can see, these are the data from the 3 largest trials, that the infants who got cooled, they have lower rates of death or disability and lower rates of CP. But there's still a lot of improvement that can be made. And so there is an ongoing search, an urgent search for additional neuroprotective strategies. So this is just a quick schematic to talk about, what's going on after these babies have their hypoxic ischemic insult. Initially, there's a primary energy failure, which occurs very quickly within minutes, and there's not much that can be done to reverse the cell death that occurs in this primary phase. But then there's this resolution during the latent period, and then a secondary energy failure. This secondary phase takes hours to days and involves apoptotic cell death, an excitotoxic cascade, inflammatory injury, reactive oxygen species. All of these intracellular cascades take hours to days. And the question is, can we do something for these babies to help reduce the eventual injury and long-term consequences? And so hypothermia has been shown to improve outcomes why erythropoietin? People always are kind of surprised. Why are we thinking about erythropoietin in the brain? It turns out that as early as in the early 1990s, it was discovered that EPO receptors were present on a variety of types of brain cells, and that both neurons and astrocytes express EPO, especially during gestation and early development, and that EPO signaling is important for the normal brain development. Then in the 2000s, and a lot of this work has been done by Donna Ferraro, by Sandra Jewell, my collaborator at University of Washington, a number of rodent models especially have shown that EPO is neuroprotective. And I'll just summarize why that is here in the slide that Sandra Jewell put together. Acutely, erythropoietin has a number of neuroprotective effects that lead to improved cell survival. And they're actually quite similar to how therapeutic hypothermia improves outcomes after hypoxic ischemic injury to the brain. So it reduces apoptotic cell death, it reduces inflammatory mediators, it reduces oxidative injury and excitotoxic injury. In addition, it has these long-term effects, and I'll show some data from Fernando Gonzalez's lab. And so we know that EPO in the long term can enhance neurogenesis and oligodendrogenesis, as well as, of course, erythropoiesis, which we all know, and angiogenesis. And all of these are thought to enhance brain repair after hypoxic ischemic insult. So preclinical studies are numerous looking at erythropoietin for neuroprotection. There are a large number of studies, and not only that, but they've been quite consistent in reporting a significant effect, in fact, a 40 to 75% decrease in the size of the brain lesion after an experimental hypoxic ischemic injury. And so to summarize a little bit of those data, I thought I'd show some nice studies that were done by Fernando Gonzalez and other colleagues here at UCSF. Starting with this one, which is a rat model of HIE, where there's a carotid artery ligation. And you can see that in the animals, they get 3 doses of EPO, and those are given on days 1, 2, and 7 after the injury. You get this relative preservation of the histology compared to the animals that did not get EPO. And in fact, the animals that got these 3 doses were able to function just as well as the uninjured rats in the Morris water maze test. And this just shows that it's really the 3 doses that make a difference. The yellow bar shows the animals that got just 1 dose, and their histology is really no different from the animals that are not treated. So this was an important study early on. Fernando and Donna have always felt strongly that having a late dose of EPO was very important. And so this was another really interesting study in which the animals who underwent this MCA, middle cerebral artery occlusion, did not start receiving EPO until 7 days after the injury. So really delayed treatment. And even then, there was a significant preservation of the histology. And again, these animals got 3 doses, so it's multiple doses. I mentioned earlier that EPO has these long-term effects of enhancing neurogenesis. So this is another study that is really quite interesting that found that EPO increased the number of new neurons that were derived from the stem cells in the subventricular zone. So this is a neonatal rat middle cerebral artery occlusion model. And what Fernando did was that at P1, they labeled the subventricular zone stem cells. And then after the MCA occlusion, they gave 3 doses of EPO. And then they stained the histology again for migrating neurons. So these are immature neurons that started off as being these stem cells because they were labeled with GFP, and then they were double labeled with double cortin, which implies that these were stem cells that are now differentiating into neurons and migrating. And if you look at the number of these double labeled cells, you can see that they're much higher. The red bars indicate the animals that received 3 doses of EPO. And you can see that there's just many more of those cells than the animals that did not get the EPO. This slide best summarizes how much data there were suggesting that EPO would be beneficial. It's an old study now, back in 2006 in Annals of Neurology. This group looked at all the experimental treatments for hypoxic ischemic brain injury and plotted them. On the y-axis, you have the scope of testing. And so some of the aspects of that STAIR criteria are listed here to the right. And then on the x-axis, we have the percent neuroprotection. So how much smaller the infarct size is after treatment with these experimental therapies. And you can see hypothermia was very highly studied, widely studied, and it had a significant neuroprotective effect. Erythropoietin, it turns out, is this dot right here. So it had almost as much testing as hypothermia, and had a similar degree of neuroprotection in the various animal models. But it's important to remember that this was a study looking at erythropoietin monotherapy without cooling. And as I mentioned earlier, the standard of care has been to cool infants with hypoxic ischemic encephalopathy. So what about preclinical data combining the two treatments? So here is one of the studies that was done. This is by Annie Fang, actually, in Donna Ferraro's lab, where they combined EPO and hypothermia and compared that to the other two groups, EPO only and hypothermia only. And if you look here at 6 weeks after hypoxia-ischemia, this is another rodent model, there really was no difference between any of the treatment groups and the untreated group. So there was no benefit in this small rodent study. However, around the same time, Sandra Jewell, who is the co-PI of the HEAL trial, she's a neonatologist up in University of Washington, she performed a non-human human primate model where you can see here they had 37 macaques. This is another experimental model of hypoxic ischemic brain injury in newborns. And what they found was, if you look at this EPO and hypothermia group, none of the infants developed the primary outcome, which was death or moderate to severe cerebral palsy. I think they followed the animals till 8 months. And that's in comparison to the animals that got either hypothermia alone or saline alone. About 44% of them had this adverse outcome. So this looked promising. So in 2009, which is around the time that I came on the scene, the rationale was quite strong for testing erythropoietin for neonatal HIE. First, there was a long safety record in newborns. We know we use this already frequently in newborns for treating anemia of prematurity. Second of all, there was an abundant amount of preclinical data that was suggestive. There were some smaller human trials in low and middle income countries that looked also promising, and I'll talk about that more later. And this, has had the advantage of being a off-the-shelf pharmaceutical, and the regenerative properties were exciting and were thought to be potentially complementary to the benefits from hypothermia. So, with the help of Roberta Ballard, who mentored me through learning how to do neonatal clinical trials, we started off by doing a phase 1 dose finding and safety trial. No one had ever combined the two, EPO and hypothermia, together in newborn infants with HIE. And so what we did was we compared 4 different doses. And what we found was this dose of 1,000 units per kilo of erythropoietin most consistently achieved the neuroprotection target levels in the plasma that we had derived from animal studies. We knew from animal studies that if you overshoot and give too much EPO, that's actually harmful. And if you undershoot, you won't get into the neuroprotective range. So this was the dose that we landed on, and there were no safety concerns. We then went on to do our phase 2 study where we combined the two, EPO and hypothermia, and enrolled 50 babies, and we randomized them in the first day, and the babies either got the EPO or saline on days 1, 2, 3, 5, and 7. And you can see that all the babies were cooled. They all got a brain MRI after cooling therapy. And then after being sent home, we followed them by phone. And then at 12 months, we brought them in for a developmental evaluation. And this was a double-blinded trial. And what we found in this small trial was that 24 of the infants were randomized to getting erythropoietin and 26 got placebo. And when we looked at their brain MRI scans, which are done at a mean of about 5 days of age, that there was a much smaller percentage of infants who got erythropoietin who had injury in the subcortical areas of the brain that are typically injured in severe HIE, so 30% versus 68%. You can see that there was also a hint of less injury in the cerebellum in the infants who received erythropoietin. Now, these areas, these structures are very important for motor development. And we followed these kids, as I said, to 12 months of age. And at that point, we evaluated their development using both the WIDEA, which is a parental questionnaire, as well as the Alberta Infant Motor Scale, which is a direct examination of their motor evaluation. And what we found was that, again, consistent with what we saw in the MRI scan, the infants that received erythropoietin had higher mobility scale scores on the WIDEA and did better on the Alberta Infant Motor exam. So these were all suggestive that erythropoietin would be neuroprotective and improve outcomes. So with those data, we were able to obtain a big U01 NIH grant to perform a large definitive phase 3 clinical trial. And the results were just published last summer. We called this the HEAL trial, high-dose EPO for asphyxia and encephalopathy. And what we did was we tested these 3 hypotheses. We wanted to use the dose of EPO that we landed on in the phase 1 trial. And we tested whether 5 doses given over 7 days to infants who are receiving hypothermia and who are diagnosed with moderate to severe hypoxic ischemic encephalopathy, whether this treatment would reduce the primary outcome, which was defined as death or any level of neurodevelopmental impairment at around 2 years of age. And we anticipated that about 49% of our patients would have this outcome, and we were powered to see an effect of reducing that number to 33%. And so this outcome of neurodevelopmental impairment is defined as a cognitive score that's less than 90 on the Bayley scales of infant development, or if they have cerebral palsy, or if they could not walk 10 steps on their own at age 2. And that was based on using this gross motor function classification system. We then also hypothesized that this treatment would be safe. And then finally, we hypothesized that the treatment would reduce brain injury on neonatal brain MRI and MR spectroscopy. And we figured that if we could enroll 500 infants and randomize them at 17 sites across the country and follow at least 90% of them to age 2, that we would have adequate power to test this hypothesis. So this is just a schematic to show what we did in this large phase 3 trial. It was double-blinded. And after babies were randomized, they either got placebo or this treatment, erythropoietin IV, 5 doses on days 1, 2, 3, 4, and 7. And they all got cooled. They all had a harmonized MRI scan after rewarming. And then after going home, we had some phone follow-ups. And then finally, at 2 years of age, we brought them in for a Bayley evaluation, a standardized neurologic examination, and a gross motor function classification system evaluation. Because of COVID-19, we did have to extend our endpoint. It was originally 22 to 26 months. But fortunately, all of these 3 measures remain valid up to 36 months. And so we were able to continue and finish all the follow-up. So I didn't go a lot into the details of HIE, thinking we're all pediatricians here, but these inclusion criteria are typical for how we diagnose HIE. Typically, babies have low APGAR scores. They require a fair amount of resuscitation at birth. They have evidence of acidosis on either a cord or early blood gas in the first hour of age. And then we performed a standardized examination that helps determine the severity of their encephalopathy based on how their tone looks, how much spontaneous activity, and they had to have meet a criteria from moderate to severe encephalopathy. And it makes sense that we went ahead and excluded infants that look like they might have some sort of other explanation for their encephalopathy, if they look like they had a genetic abnormality or were microcephalic. Families that we felt were unable to return at age 2 were not enrolled. And we had a few babies that looked fine at birth, but then sometime within the first hour had a sentinel event and became encephalopathic, and we did not include those babies. So this is the consort diagram that shows you the babies that were enrolled in the HEAL trial. We screened 1,300 infants, basically across 17 sites in the US. We enrolled infants who were at least 36 weeks gestational age and who were undergoing cooling therapy. And we ended up enrolling the target 500. You can see that most of the babies that were excluded had mild HIE, which is another topic in itself. And our overall consent rate was 68%. And there was one baby that actually was erroneously randomized. And so we ended up with the 500 in our modified intention to treat analysis. And of these, about 3/4 had moderate HIE and 1/4 had severe HIE. And after randomization, you can see that both in the EPO group and in the placebo group, we had excellent follow-up. We were able to get over 90% follow-up, which was our goal. So table 1, always want to make sure that the 2 treatment groups are evenly distributed in terms of other potential confounders. And you can see here that was the case. So a number of infants had exposure to maternal fever or maternal chorea amnionitis, but there was no difference between the 2 groups that was significant. There was a sentinel event in about 1/3 of the babies, which means that there was some sort of unexpected complications, such as a uterine rupture or a placental abruption or a cord prolapse that led to the HIE. But again, those were evenly distributed between the 2 groups, and a C-section delivery was present in about 2/3. This just shows that the infant characteristics were also the same pretty much between the 2 groups, EPO and placebo groups. You can see that these infants were very sick. Almost all of them required resuscitation for more than 10 minutes. You can see their APGAR scores were low, and they were quite acidotic, and severe encephalopathy was evenly distributed between the 2 groups. So this graph shows our main finding. When we looked first at our primary outcome of death or any neurodevelopmental impairment, as expected, about 50% in the whole cohort had this outcome, but there was no significant difference between the 2 treatment groups. And again, if you take that primary composite outcome and look at just the parts, death alone, or low cognitive score, cerebral palsy, there was no significant difference between the 2 treatment groups. You can see the numbers here. I don't have to read them out. We then did a number of stratified analyses that were pre-specified. Could it be that EPO would be beneficial only for infants with moderate encephalopathy and not severe? But again, if we stratified by severity, there was no benefit to treatment with erythropoietin. Similarly, when we looked at just females and males, there was no difference. So there was no evidence of benefit from erythropoietin. We had a number of secondary outcomes. This is one of them that we were always really interested in, because there was always the possibility that erythropoietin would help by shifting the outcome so that there would be more mildly impaired infants and less moderate to severe neurodevelopmental impairment. And so we've created this 4-level ordinal outcome. But again, when you look across the two groups, erythropoietin and placebo groups, there was no difference in any of these levels of neurodevelopmental impairment. That brings us to the second hypothesis, which is that we thought this treatment would be safe. And the way we tested this hypothesis was to define these 9 serious adverse events. And so they're listed here. The first 4 were chosen to be considered serious adverse events. Some of them are obvious, like death. The other were chosen because they've been described in adult clinical trials where erythropoietin was tested for neuroprotection. Or they were described in adults who are receiving chronic erythropoietin for, say, renal failure or for cancer. We then also included these additional 5 serious adverse events because they're serious life-threatening conditions that are frequently seen in these infants who are in the NICU being treated for HIE. And what we found was, if you look at any of these SAEs individually, there was really no difference between the two groups. But when you look at them in aggregate, so the first aggregate measure was the total number of SAEs per child. It was 0.86 in the EPO-treated group and 0.67 in the placebo-treated group. And that was a significant difference. Similarly, if you look at the percentage of infants who had at least one of these SAEs, it was higher in the erythropoietin group than the placebo group. And again, this was just barely a significant finding. So this was a very unexpected finding that there is potentially some safety concerns, especially during the neonatal period. Our third hypothesis was that EPO would improve outcomes on neuroimaging, like we saw in the phase 2 trial. And so just really quickly, the 2 most common patterns of brain injury that we see in HIE are this central gray matter injury that I showed earlier that was reduced in the phase 2 trial in babies that received erythropoietin. We also see this pattern of perisagittal injury. So in the watershed areas and the parts of the brain that are being fed by the small capillaries that are between the major vascular territories. Here's the MCA territory, and then here's the ACA, anterior cerebral artery territory. If you look in between those 2 vascular territories, we have this perisagittal watershed zone. And so we thought we would see potentially less injury in either central pattern, peripheral pattern, or both. To test this hypothesis, we had to put a lot of energy and work into harmonizing the MRIs. These were clinical MRIs being done in babies at 17 sites using a variety of different MRI models and makes. And so we created a protocol that harmonized tissue contrast and resolution across these sites. And this was largely thanks to some of my collaborators, Bob McKinstry and Jessica Wisnowski, who put a lot of work into this. But unfortunately, the results were similar. We did not find a difference in any of the MRI measures, whether it was total MRI injury score, severity of MRI injury, or pattern of injury. There was no difference between EPO and placebo groups. You can see that about 45% of infants had moderate to severe brain injury despite getting cooled, but that was no different between the EPO and placebo groups. We also harmonized MRS, and we're able to see whether there's evidence of benefit on MR spectroscopy, looking at some of these ratios, but there was no difference between the groups. So these negative results actually mirror the results of a previous large clinical trial looking at erythropoietin for neuroprotection in preterm infants. So the other, my co-PI in the HEAL trial, Sandra Jewell, she was the PI of a large randomized controlled trial of erythropoietin that was looking specifically at preventing preterm brain injury in infants. And this was published also in the New England Journal just a couple of years ago, or I guess about 3 years ago now. And so what was the rationale for that study? There were 2 small human trials that predated that large clinical trial. The first was also by Sandra Jewell and her colleagues at University of Washington. And similar to our early trial, it was really a dose finding study where they found that the same doses we found, 1,000 units per kilo on days 1, 2, and 3, achieved the neuroprotective plasma levels that they were targeting based on the rodent models. And also that it appeared safe through hospital discharge. Similarly, there was another Swiss group that had published a small phase 2 trial where they found that this higher dose of erythropoietin given 5 times in the first 2 days of age appeared safe. And again, this was just through hospital discharge. So those were the 2 prior human studies. But again, the large phase 3 study was negative. So this was an even larger study. They enrolled 941 preterm babies. They were born between 24 and 27 weeks gestational age. They got 7 doses of this large bolus of erythropoietin, and then they continued to get subcutaneous EPO 3 times a week until they reached 32 weeks gestational age. And if you just scan really quickly this you'll see that none of the outcomes that they looked at, whether it was death, the primary outcome was death or moderate to severe neurodevelopmental impairment at the bottom. But you can see that all the various components were also not benefited by EPO. And they also did some stratified analyses and did not find any benefit. So at this point, I thought I would switch gears a little bit and kind of think about what lessons might be learned from this journey. So the question on everyone's minds is, why did our phase 3 trial findings differ from what we had expected from our previous studies? And of course, the first answer is the easiest, which is that we are just once more reminded that what works in animals does not always work in humans. And this has definitely been true for the field of neuroprotection for adult stroke. There's just been, as you saw from that previous graph, we're still looking for treatments that work. But secondly, I think it's important to remember that the preclinical studies that I showed that suggested EPO was a potent neuroprotective agent were done primarily in rodents. And they almost all were looking at EPO monotherapy without combined therapeutic hypothermia. And in fact, while we were running the trial, additional studies started getting published. So there's a group in New Zealand, Alistair Gunn's group, where they have a neonatal sheep model of HIE. And then there's a group in the UK that has a piglet model. And these groups started looking at combining EPO and therapeutic hypothermia and found that there was little to no benefit. And in fact, the New Zealand group, the sheep model, they also published a study where they cooled the sheep after hypoxic ischemic injury. And then after rewarming, they gave EPO, thinking that maybe the long-term benefit might still lead to improved outcomes. But what they found was that this EPO given after rewarming actually led to increased neuronal loss. So these preclinical studies that came out during our trial did not suggest that there would be benefit of EPO being added to cooling. And this may be because, as I mentioned at the beginning of this talk, both EPO and hypothermia have very similar acute neuroprotective mechanisms. And it may just be that hypothermia works quite well, and that if you add EPO to it, it may just make it very difficult to see any additional benefit. So this is a nice schematic that I thought could just, we could use as a way to visualize clinical translation from starting from bench research, going into animal models, then a phase 1, phase 2, and phase 3. So that's the journey that I'm trying to describe to you that we've been on. And putting things into context, I think in terms of the HEAL trial and term HIE, if we had had more preclinical data that showed that combining EPO and cooling would be beneficial, I think that would have made it much more likely that our phase 3 trial would have found benefit. So it's not really a failure of animal models and translating. I think it's more that it's really important to make sure that our preclinical models recapitulate exactly what's happening in the clinical world. So that's a lesson, I think, for HEAL. What about the preterm brain injury? I think in the preterm brain injury scenario, there really wasn't a lot of phase 2 clinical data. There was actually no small efficacy studies suggesting benefit. It was mostly observational studies of large cohorts of preterm infants, and some of those observational studies suggested that infants that got erythropoietin for other reasons, for treating anemia of prematurity, some showed that those infants did better and some didn't. But there really was a dearth of early efficacy data. And of course, the animal models that I showed really were not models of preterm brain injury, which is a very different mechanism of injury from acute hypoxic ischemic injury in a term newborn brain. But that said, we have to also remember that our phase 2 trial of EPO and cooling looked promising. So just having a promising phase 2 trial is not always going to it's not going to be a given that the phase 3 trial will be positive. And so why is that? What are the limitations of the phase 2 trial? I think our data are quite demonstrative and are interesting to help answer that question. So as I mentioned, we enrolled 50 babies and we followed them to 12 months in the phase 2 trial. And when we compared the EPO and placebo groups, this Alberta Infant Motor Scale test at 12 months, the EPO kids did much better than the placebo treated infants. But then it turned out that out of our 50 infants, 2 of them had a genetic abnormality. One ended up being diagnosed with myotonic dystrophy, and one had a brainstem malformation. And you can have these other conditions and have HIE, or they could be a mimicker of HIE. But in any case, these 2 infants were going to have a poor outcome regardless. And they happened both to be randomized to the placebo group. And so they made EPO look better than it probably would have been. And in fact, if you take those 2 infants out and just look at the other 48, you can see there actually was no difference in the motor outcomes between the 2 groups. Now, for the phase 3 trial, interestingly, the same percentage, 4% of the 500 babies, were found to have some sort of other genetic abnormality. But the benefit of a large phase 3 trial is that they're evenly distributed between the 2 groups. And so what we saw in the phase 2 trial, with them all being placed in the placebo group, is unlikely to happen. And of course, the other benefit of the phase 3 trial is we had 2-year follow-up instead of 12 months, which is a big difference in terms of our ability to see a true difference in neurodevelopment. So this brings me to the important conclusion, which is that I think both HEAL and PEANUT trials, even though the results were disappointing, these were very successful trials. They were both highly successful in terms of enrollment and in terms of follow-up rates. We had, very closely followed protocols, very close monitoring of data quality throughout, and a very highly effective data coordinating center, DSMB, and just overall was well managed. And when the results came out that were so disappointing, our NINDS project scientist, some of you might know, Adam Hartman, he said, we like it when a no is a no and a yes is a yes. And I think that is definitely true for our study, that we know the answer is no for erythropoietin combined with cooling. And as they say, when one door closes, another one opens. And in this case, I think several doors open. So I wanted to end on a somewhat more of a positive note in that there are a lot of new potential therapies that are on the horizon. We've talked today about EPO and hypothermia. There are a lot of agents that are being tested that can counteract a lot of these mechanisms that lead to cell death in the brain after hypoxia ischemia. And I actually think we have a lot of reasons to be optimistic. First of all, I think there's just this real big increase in collaborations across sites and across countries in this field. There are now new patient advocacy groups that are getting involved. And our group has gained a lot of clinical trial know-how. Some of the things that I think are exciting, I wanted to just mention. First is, in the preclinical realm, there is an effort to coordinate pipelines across multiple laboratories to decrease inefficiencies and just to move progress along. And so one example of that is the Bill and Melinda Gates Foundation Neonatal Neuroprotection Group. This group is testing, in a concerted fashion across multiple labs, potential neuroprotective agents in the organoid model at Stanford, rat model in Germany, piglets in the UK, and the sheep model here at UCSF in MML Teep's lab. And he, with Yasmin White and Yana Mike, they're all working really hard to test some of the agents that I showed on the previous slide and more. So that's exciting. Clinically, I think just as important as it is, as I mentioned earlier, that the preclinical model should match the clinical scenario, it's also important that we enroll patients who really are matching the underlying pathophysiology and pathogenesis that we're trying to target. And for those of you who are not in the nursery very often, you probably are not as aware of how broad and heterogeneous this group of patients is. Patients that are diagnosed with hypoxic ischemic encephalopathy may have a whole variety of different causal pathways to getting them to being born with low APGAR scores and acidosis and being encephalopathic. And the timing of the injury is also very heterogeneous. As I mentioned, some infants are exposed to a sentinel event, and we can say for sure there was a uterine rupture at this time, and this is what happened. But that's a minority of patients. And so I think it's really important that we work on developing better biomarkers to target a homogeneous population in future trials. And so we're doing that. As you can imagine, we've collected a lot of high quality data from these 500 infants, from MRIs to EEGs to a variety of biomarkers of injury. We have placental histology. And so hopefully we can use some of this learning to improve our design of clinical trials in the future. And I thought I'd just touch on some of the work that's being done. So Marie Cornet, a neonatologist in our department, she has a K23 to really focus on the role of inflammation and infection. As I mentioned, a lot of these babies are born encephalopathic, and we're trying to target the babies that have an acute sentinel event and hypoxic ischemic injury, but some of them actually may not be in this bucket. They may actually be more encephalopathic because of being exposed to intrauterine infection. And so do those babies deserve a different type of therapy? At least in animal studies, we find that cooling does not work as well in animals who are exposed to an inflammatory environment. So that's one direction. So Hannah Glass and Adam Numis are working hard to analyze the video EEG tracings from our, we have 150 of our 500 subjects who were born at sites where they can perform continuous video EEG recordings. And so they are analyzing these recordings to see if we can use them to better correlate with which babies are going to have worse outcomes. And really importantly, can we combine that data with other clinical data, such as the brain imaging, clinical exam, to better understand which babies are really the ones that have suffered a hypoxic ischemic injury. We also have, as I mentioned, plasma biomarkers we're looking at, both brain injury markers, as well as markers of inflammation. And we'll be correlating these with outcomes. And then with Emmons' help, we're hoping to also work with the Gates Foundation to look at our urine samples to see if we can develop some metabolomic profiles for predicting outcomes in HIE. And finally, in the last few minutes, I just wanted to mention that HIE is much more common in low and middle income countries. They, represent the vast majority of cases globally. Here we are in the high income countries. And there have been 6 small phase 1, phase 2 trials looking at EPO monotherapy. So we know that cooling is not indicated in these low and middle income countries. Could EPO given alone without cooling be a helpful treatment? And so there is a large trial that's underway that'll be asking this question, where they'll be giving erythropoietin alone without cooling. So that's to be determined. And then finally, people are also asking, are there other indications for trying erythropoietin monotherapy? One would be, so we heard that in preterm brain injury, if you give all comers EPO, that didn't seem to prevent injury in the brain and didn't prevent poor neurodevelopmental outcomes. But what if you take just preterm babies who've had a significant injury? Can erythropoietin help repair the brain? So those are questions that are being asked in ongoing trials. There are also babies who are born who seize a few hours after birth and are found to have a stroke. Could it be that if babies with stroke, not this global hypoxic ischemic injury, but have a stroke, could they benefit from erythropoietin monotherapy? And then finally, babies who have mild HIE, too mild to be treated with cooling, some of those have poor outcomes. So it's possible that EPO may be beneficial. So that concludes my talk. I think the take-home points are, first, that we learned from our HEAL trial that EPO should not be given to infants with HIE who are undergoing cooling. That there are a lot of exciting therapies coming down the pipeline. I think, we want to remember that the preclinical models really should recapitulate the clinical scenarios as much as possible. I'm personally very excited about the coordinated efforts across laboratories, and also the development of better clinical biomarkers so that we can identify more homogeneous patient populations. And finally, there may still be some use for EPO monotherapy in some situations, and that's to be determined. And I'd like to thank all the people that made all this work possible, especially my main mentor, Donna Ferraro, who's been a mentor for me since day one. And a lot of the folks here at UCSF that I've highlighted in red here, including the awesome Nicken team who made our trial run so smoothly here at UCSF. And it was a large group of people, as you can see. And I will stop there.
Thank you, Yvonne. That was great. While we're waiting for people to come forward with questions, I had a question about, I think it was, did you say 20 kids who ended up having the genetic syndrome? And yeah, are there, I know it's not a huge number, but are there ways of thinking about trying to identify up front who those kids might be? And I mean, I think like even talking about genetic syndrome, obviously for a family is something that's difficult. And then first you're talking about HIE and then you switch and, I don't know, I'm just wondering if there's ways to think about identifying that group.
Yeah, I know. I think it's a really interesting group. So Adriana Morel, who's one of the child neurology fellows, she's taking this on. So she and I are looking more closely at these 20 kids, and we actually just reached out to all the sites that enrolled those 20 kids to understand what led to the genetic testing. Was it dysmorphic features? Was it, something in the family history. What was it that led them to get the genetic testing? So I don't have an answer for you yet for sure, but we're going to learn more about what those conditions were and if there's some way to identify them sooner. She's going to put an abstract together for CNS and hopefully PAS.
Great.
Yeah.
Jim.
Hi, great talk. It was large enough, I wonder, and this might already be in the works, if you've considered something like latent profile analysis or some other machine learning approach to look at the precursors, all the clinical phenotypes and some of the outcome data for patients with different trajectories from, origin to outcome, and then, kind of in a personalized way, then look at some of the downstream things. That might already be in the works.
Thank you. Yeah, it is. We have so much data. It's been really interesting thinking about how to organize it and how to use it. What we're doing right now, and Hannah Glass is actually leading this effort, is we're curating a set of predictors in each of the realms. So neuroimaging, EEG, serum biomarkers, placenta, clinical. And we are going to use some machine learning to see if we can do a better job in creating a predictive model, if that's what you're asking.
What I'm suggesting is not doing them independently, but using them all. So instead of controlling for your confounders, bring them into the family and look at them and see how they affect the overall trajectory. It's a hypothesis-free method. You don't really go into it with an a priori notion. If there are clusters of patients that are similar across trajectories, how many there are, and the model will give you those ideas.
Mm-hmm.
It requires a large number of subjects in order to do it, but.
Mm-hmm. Yeah, we're doing something to that effect, but not throwing everything into the model. We're fine. For instance, we're doing kind of a supervised machine learning, I guess I would say, as opposed to like a deep learning where we're just throwing everything in. Yeah,
great talk. Thanks you for the
Thank
summary.
Jim, you want to go ahead?
Yeah, really, really nice work, Yvonne, over a long period of time and across, a lot of ground. One of the things that can be challenging is when you validate your null hypothesis and then getting that published. And you had a really beautiful paper in New England Journal, and I'm just wondering, do you have any take-home experiences from doing that and being able to take this? What you probably weren't hoping to see when you started, but then be able to get that information out in a way that's meaningful and impactful.
Are you asking more about how to communicate the results?
Yeah. Did you learn something about how to communicate it when you falsify your hypothesis? Right.
It's so interesting you asked that, because I just gave a shorter version of this talk at the Newborn Brain Society meeting. And, people in this field have heard me talk about this many times. And I think they've seen a gradual evolution of my talks in that they've become, more optimistic and hopeful. It was very hard at first. It was a huge disappointment. And so it was hard to really, have that bent. So I don't know if that answers your question at all.
Yeah, I think it's just something that we all kind of face at some point. And when our experiments on the bench side, or when our hypothesis on the clinical side don't go the way that we think, and not being overly wedded to it and being able to still get a message out. That I think that's a nice feature and a challenge. But
it is. We all know that a negative result is still progress, and we need them. That's the only way to have progress, but it's still hard when it happens, and to maintain that and to communicate that. But I think in this case, I think we've learned a lot from it, and it's progress. And hopefully, the next 10 years we'll have something that works.
Yeah.
Well, Yvonne, I would just say, I know we have another Jim who's going to ask a question, but I just say that, you designed and implemented the right study, right? So you did answer the question, right? You did the dose finding, you were powered appropriately, you had the right endpoints to that you collected. You had high levels of follow-up. So the fact that it's negative, it's not, you can't critique it based on your design or implementation. So
Thank you for that. I definitely agree with that.
go ahead, Jim, number 3. You might be last.
Yeah, I figured all the gyms have to ask a question today. Huh? Yeah. So I was just curious for hematologic parameters, were there a difference between the two groups in the big study versus the little study? It was to the same extent, whether there's some difference that might be explained by that.
Oh my goodness. I wish Sunny were here because she's really interested in that. In the preterm study, they actually looked at hematologic parameters, and she's really interested in transferrin and how this might have affected transferrin. In our term infants who just got 5 doses, we actually didn't look that closely. We just didn't think that the 5 doses early on was going to make much of a difference hematologically. These babies all have they get a lot of blood drawn, so they all get their crib coming down, and then no one gets polycythemia despite, the EPO. So we did not look closely. But Sunny Jewel she's actually trying to get funding to look more closely at your question in the preterm population.
Well, I think in the preterm population, they actually had higher rates of iron deficiency in the treated group, right? Isn't that, is Betsy on still?
Yes.
Betsy.
I am still on. Yeah. That was kind of, my ears perked up about this part. But also, Yvonne, just to say thank you for a beautiful summary of all of that data. And, I could ask a similar question about the impact of the blood vessels, but we'll stick to the hematologic cells for the minute. Yeah, as you are well aware, we do still use EPO for anemia prematurity in our nursery, and that's not a common practice, across the country at this point. And so we've been looking at the follow-up papers from the peanut trial, looking at the percentage of iron deficiency in the setting of giving EPO. And I know what our data is at this point, that like in our nursery, about 95% of our small babies who are given EPO for anemia prematurity are iron deficient as measured by ferritin and zinc porphyrin levels. And I think the peanut trial was similar, but they were very aggressive about their iron dosing, up to 12 mg per kg daily of iron, which I feel like our nurses would give us a hard time for. So yeah, and in fact, Fernando, who also, I was going to see if I could call him out, but he's no longer on the call, but Fernando was highlighting recently like some aspects of their trial, and that Sunny told him offline that she thinks that because they couldn't overcome the iron deficiency in the setting of the EPO dosing, that could have been a reason that they weren't able to impact the overall neurodevelopmental outcomes. So I found that very interesting also, and I think just speaks to how many different cells are affected by EPO.
Yeah, I was curious because for giving EPO to treat people who can't make red cells, if you don't give them enough iron, the EPO is not going to work, right? So it's what you're sort of saying with the prematurity. And if you didn't see the same sort of shifts that you might have expected to see based upon preliminary trials, maybe that was a confounding factor that needs to be looked at. But or it could be working on something completely different, but just tossing out some ideas.
Thank you guys so much for listening and for your support. I have to get on another call.
Yeah, thanks everyone so much for joining us. Bye.
Thank you so much. Thanks, Roberta.